This is an overview of exogenous insulin therapy in diabetics by Kate Smith, Ethan Meyer, and Kevin Warren. The first step to managing your blood glucose is to check your blood glucose. Here I am checking my blood glucose in the middle of a study session after eating several handfuls out of a bag full of Skittles. We're going to see if I have functioning insulin in my bloodstream. It's recommended that type 1 diabetics check their blood glucose 3 times a day, and type 2 diabetics should check their blood glucose at least once a day. There I am with a 113, so I have plenty of glucose circulating up to my brain, so Skittles must be an excellent study food. The physiology of insulin. It's naturally occurring within our body. It decreases blood sugar by allowing glucose uptake into our cells and conversion of that glucose to glycogen in the liver, in the muscle cells, and in excess into adipose tissue. Insulin also stimulates the fatty acid packaging into triglycerides, which we can use as an energy source later. The pancreas is the organ that produces insulin. The islet of Langerhans is the region of the pancreas that produces these hormones. There are several hormone-secreting cell types that are in the pancreas. They include alpha cells, beta cells, and pancreatic polypeptide cells. Beta cells are the cells responsible for producing and secreting insulin and another hormone, amylin, which has an effect in the blood glucose management pathway that we'll discuss in a second. Here's a diagram of the pancreas showing the islets of Langerhans. So here is the feedback pathway, the insulin feedback pathway in a diabetic, or actually it's just in a normal person. The green box over on the left is indicating blood glucose rising. It can rise from ingesting some carbohydrates or food from a meal or snack. It can also come as glycogen is broken down in the liver and released into the bloodstream to keep some sugar circulating through the body. In response to that elevated blood glucose, the pancreas beta cells release insulin and amylin. The insulin opens up channels that allow glucose to be transported into cells. It also encourages the liver to store it as glycogen and encourages the muscles to take up the glucose as muscle glycogen. Again, in excess, the adipocytes will also store some glucose from the blood. As that blood glucose starts to fall, the pancreas alpha cells release a hormone called glucagon, which encourages the liver to break down more glycogen, which will release more glucose into the blood. There are many different types of insulin. In diabetes, the body has either developed a resistance to this insulin from being constantly saturated or is unable to make its own. Some of these patients will need insulin injections to help control their blood glucose levels. When we as healthcare practitioners are prescribing or administering insulin, it's important to know each insulin's onset, peak, and duration. Onset refers to when the insulin starts causing an effect in the target tissues. Peak refers to the peak of action, and duration relates to the length of time insulin exerts an effect on the body. These insulins fall into 5 categories: rapid-acting, short-acting, intermediate-acting, long-acting, and pre-mixed. This graph demonstrates the effect of equal amounts of different types of insulin over time. So on the y-axis you can see the effect, and on the x-axis you can see that effect over time. The rapid-acting insulins like Lispro, Humalog, Aspart or Novolog, and Glulicine or Apidra have an onset of 10 to 30 minutes. They peak between 30 and 90 minutes and last 1 to 5 hours. Their role in insulin management is as rapid-acting insulin coverage for meals eaten at the same time as the injection. This type of insulin is used with a longer-acting insulin, either a long-acting or an intermediate-acting insulin. Short-acting insulins, like regular insulin, also known as Humulin or Novolin, these have an onset between 30 minutes and an hour. They peak between 2 and 5 hours and have a total duration between 2 and 8 hours. Their role is as short-acting insulin coverage for meals eaten within 30 to 60 minutes or when treating an acutely elevated blood sugar. Regular insulin is often given in the ER to treat acutely high blood sugar, given subcutaneously or IV, or in combination with NPH and sliding scale therapy. NPH is an intermediate-acting insulin. One thing to note with short-acting insulin is that if you do administer this insulin or your patient takes this insulin and then forgets to eat within that 30 minutes to an hour, they run a good chance of becoming very hypoglycemic. That can be very dangerous. The intermediate-acting insulins, such as NPH or Lent, have an onset between 1 and 2.5 hours. They peak between 3 and 12 hours, and their duration is 18 to 24 hours. Their main role is as intermediate-acting insulin coverage for half the day or for overnight. This type of insulin is often combined with the rapid or short-acting insulin and is usually given twice a day. This is an example of a pen that comes pre-mixed with some intermediate and short-acting insulins. These pens have an onset between 1 and 12 hours, a peak between 1 and 12 hours, and their full duration is 14 to 24 hours. So these are generally injected twice a day right before mealtime. The long-acting insulins, such as Ultralente, Lantus, Levemir, have an onset between 30 minutes and 3 hours. Lantus has no peak, and the peak for the others is between 6 and 20 hours. Their duration is 20 to 36 hours, and their main role is as long-acting insulin coverage for the full day. So this type of insulin is often combined, but this one is usually given once a day as a background insulin, and then a rapid-acting or regular-acting insulin is used as bolus and coverage for meals. In an acute care setting, regular insulin, which is the only insulin that can be given IV, is often used in an IV pump. These patients have to have IV access, and they're hooked up to an IV pump, so they get a measured amount of insulin per time over the course of the day. Their blood glucose is checked every hour, and that number is put into the pump, or is put into a calculation which then sets the drip rate for the pump. So in a lot of places in cardiac ICUs, the calculation is the blood glucose minus 60 multiplied by 0.3, and that gives you units per hour. ICU calculation is set by the intensivists, and this actually can bring your patients under a little bit tighter control with a higher risk of hypoglycemia, but it's blood glucose minus 80 multiplied by 0.3, and that gives you your units per hour. You should always check and see what the standard ICU or CVICU protocol is in the facility that you're working at. Sliding scale insulin is often what's used up in the telemetry units or in other inpatient settings where the patient does not have IV access. This is a fixed amount of a long-acting insulin and combined with regularly administered regular insulin or rapid-acting insulins. The amount of the insulin that's given directly relates to the current blood sugar of the patient before they eat, preprandial, and its corresponding insulin order, therefore correcting any pre-existing hyperglycemia. So here's an example of the chart. The blood glucose before the patient ate would be measured, and that number would be put into this table, and it would calculate the insulin dosage for the nurse or PA or doctor, whoever's administering that. This is very standard in managing patients inpatient where they do not have an IV in place. And that concludes our short little talk on exogenous insulin administration. Any questions, feel free to email